have with us Dr. Jay Kumar Arora. He is a licensed psychologist, speech intervention specialist, and tobacco cessation expert. He has done masters in psychology, postgraduate diploma in mental health, postgraduate diploma in rehabilitation psychology, postgraduate diploma in speech therapy intervention. He is a certified tobacco control and cessation expert from Tata Memorial Center, Mumbai. He is presently working as psychologist and clinical head in Nurturing Minds group of clinics located in Meerut, which provides treatment for mental health, audio diagnostic services, speech therapy, and other rehabilitation therapies. He has also given his contribution in the field of adolescent screening for nicotine dependence and in treatment of childhood onset fluency disorder, that is stuttering. So welcome Jay, to our group. This is Indian Institute of Homeopathic Physicians, Delhi State Branch. We have with us our central team members, Dr. Rajendra Singh, Dr. Geeta Mongia, our president sir, Dr. Mukesh Chavla. So we all welcome you and looking forward very for a very good session here.
Right. Thank you, ma'am. A lot of thanks for IAHP for giving this opportunity to me, and special respect and regards to seniors, Dr. Mukesh, Dr. Rajendra Singh, and Dr. Geeta, ma'am. So I can start now if everyone has joined. Okay. So I've made a small presentation on the topic, that is basics of CBT. So CBT, that is cognitive behavior therapy. First of all, we are required to understand some close terms before starting the topic. So I'll just share the screen. So, oh, so these terms, the visual. What is a visual? It can be, yes, it can be physical, or it can be imaginary also. So even a dream is sometimes considered a visual. So visual is anything which is stimulating, which acts as a stimulant, which starts the cognitive process. Visual. And event is a situation. For example, there is a situation in which a car is going at a very fast speed on a road. So a visual and a situation or an event or an incident, a series of visual series of happenings, that is an event. What is a thought? Thought is our own production, the own thinking, a person's own perception. It is not happening somewhere else. It's not happening in physical environment. It's happening in our own mind, in our own brain. This is the thought. I'll give examples also. And then comes the feeling and emotion. So we need to understand what is feeling and emotion. Right. So a feeling, for example, I'm alone in my house. So I'm feeling alone, but emotion is loneliness. I'm feeling happy, but emotion is happiness. So feeling is a pathway to the emotion. If I'm feeling scared, the emotion could be fearful. So I'm feeling sad, the emotion, the last outcome of that feeling is sadness. So happy, happiness, sad, sadness. So the ness, the suffix of ness is the emotion. Similarly, thinking is a pathway to the thought. So I am thinking about it. I'm thinking about an answer, but what thought comes to my mind? That is the last outcome of my thinking. Thinking is a pathway, thought is the final destination. Feeling comes and goes, but emotion stays. So visual, I'll just share the screen again. So visual, event, thought, feeling, now belief. So belief, the smaller brother of belief could be opinion. So very strong opinion, very strong self-image could be a belief. For example, a belief could be that I'm very good at driving. So I'm very good at making paintings, or I'm very good at cooking. So belief is a deeply held idea accepted as true. Now, this belief is 100% true for the person, individual person. Next is the behavior. Now, when we see this from a top to bottom view, visual, event, thought, feeling, and belief. So the behavior comes. So, what could be the behavior? I'll just give an example so you can understand it better. A homemaker which is very good at making a sweet dish, maybe kheer or maybe a gulab jamun. Now, if she visits any other home and they serve gulab jamun there. So the visual is the gulab jamun event. Then thought comes that even I can make a better gulab jamun. Feeling, belief, and this behavior. Now every time it's repeating. Every time she's getting motivated from that. Every time she's feeling privileged. So this is the series of what is happening on a cognitive level. So visual, event, thought, feeling, and behavior. Now, understanding the CBT. CBT full form is cognitive behavior therapy. Now, we understand the behavior, and the cognition part is, of course, all these aspects. So, it is a structured and evidence based psychotherapy. I would rather say that it is the most commonly used psychotherapy. It is the heart of psychotherapy. At the end of this presentation, we'll understand better that how CBT has given birth to even specialized therapies, how the advanced version of CBT are being used. It is a goal oriented and problem focused approach. So we have to understand the goals of CBT before starting the therapy, and it aims in solving a problem, helps modify unhealthy thinking pattern. So now I'll start with CBT. But before starting the CBT, we have to understand what is REBT. So REBT stands for Rational Emotive Behavior Therapy, which was given by Albert Ellis in 1955, and it was then more elaborated, more expanded by Aaron Beck. So Aaron Beck is a very famous person. He has his institute also, Beck Institute of Cognitive Behavior Therapy. So modern CBT combines cognitive and behavior method. So REBT is the mother of CBT, and REBT could be considered as version 1 of CBT. So CBT is version 2. So for CBT understanding, we have to understand what REBT aims for. So REBT, rationality. So what is rationality? Can anyone tell me? Can I ask questions?
Yes, sure, sure. It can be an interactive session, sure.
Yeah. Can
I think
anyone
a logical thinking is what being rational means.
see? Understanding rationality. So, rationality is the ability to see things how they are, not by my own perception or driven by my emotions, not eliminating the emotions also. So, rationality, I'll give an example. So, we have all witnessed the COVID pandemic. So, some persons were very negative at that time. Some people had opinion that yes, 20% of the population will not survive. Some people were panicking. So, what is this thinking? This is not the rational thinking. So, rational thinking is that yes, it is a pandemic, but it will act like a pandemic only. It will act like a viral fever only. Another example of rationality is that if an athlete gets injured on leg, a very dedicated athlete, now the rational thinking aims that okay, no problem, there is an injury. So the rational thinking is that no problem, I have an injury on my leg. It will, yes, affect my performance maybe for 1 month or 2 months, but ultimately I'll recover. It is limited to the injury level only, not my performance, not my soul being. So this is rational thinking, but emotional driven mind will say that, oh, now I will not be able to perform. It will impact me in the long run. I will not be able to hit those goals which I have considered before. It will affect my calendar also. It will affect my stamina also. I have to take bed rest. I'll be back. So these all thinking is emotionally driven thinking. So rationality is seeing how things are. Now there's another thinking, that is the logical thinking. Now logical thinking is the extreme. Logical thinking could be, for example, if there's a pandemic, how can it affect me? Or it's just a matter of days. Actually, logical thinking is sometimes robotic thinking, how the machines calculate. It's very calculative. So I'll give another example. Rational thinking based on evidence and facts, accepts uncertainty, encourage healthy emotional responses, promotes problem solving behavior. So now comes the concept of three minds. So CBT believes that there are three type of mind. One is the logical mind. It only considers the facts and analysis. So for example, there is a census report, and when we only consider the facts and analysis, no ground reality, no humanistic approach to it. This is the way how machines can interpret, not how human beings can interpret. Now, second is the emotional mind. Now, this is extreme, considering everything from the emotional aspect. And the middle one is the rational thing. So, one extreme is the logical thinking, logical mind. Another extreme is the emotional mind. So, balance of this thinking is called wise mind. So, REBT focuses on developing the wise mind, a balanced approach, balance of logic and emotions. These are the goals for REBT. Okay. So, I just come forward to the ABCDE model of CBT. So, what are the ABCDE model of cognitive behavior therapy? First of all, just considering the ABC, only the ABC part. So A could be activating event. So what could be an event? It can be a visual, it can be an imagination also, it can be a news also. Activating event could be anything which is coming in future also, any upcoming event also. So any aggregator on general basis, anything which activates any visual, any happening, or any situation, or a person is participating somewhere, that action, that activating event is called the A. For example, if a person is walking on the road, he's going to his home, he's walking on the footpath, and he sees, or he just sees his school friend, long back friend, which is going by the road in front of him. Now, this could be the activating event, the action, the situation. Now, this person sees that friend, and the friend doesn't see him back. So, a school friend, a long back friend, is observed, is seen while walking, and that person doesn't sees him back. So this is an activating event. Now I'll stop the presentation and I'll tell you how CBT main concept thinks about it. So according to CBT, any event, any action does not have any result of its own. It cannot create an emotion on its own. It doesn't have a last meaning. So it is the person who brings out the last meaning of it. So if the person has seen his long back school friend actually doesn't have any meaning. So it's person's perception, its own thoughts, his own emotion that will all lead to the behavior. If there is an accident happening on the road and a person is seeing it, actually that event doesn't have any meaning on its own until and unless we take a meaning of it. We can say that yes, it was rash driving, so the accident was going to happen. We can be neutral on that. These accidents usually happen oftenly on this road. There's no big deal. Or emotion driven person will say, oh, ho, what will happen now? Somebody has lost his life. They can get sad while seeing the accident. So, in reality, any event, any action, any aggregator doesn't have its own meaning. It doesn't give direct emotions. It's just a happening, it's just fact. So, I'll continue the presentation. So, A is the activating event. Now comes the B. Now, B is the belief of the person. Now, this is a unique belief, individual belief, which is driven by a mood also. So, the same person, when going on the road, walking on the road, sees another friend, a long back school friend, and that friend doesn't see him back. This person says, I'm not worth it. Even the long back school friends now avoid me. He just avoided me. He could have seen me. Now, this is his own belief. What is the belief? Worthlessness. What is the belief? Now I'm not getting importance. What is the belief? People are avoiding me. So here comes the belief. Another example is that a housewife cooks a dish and serve it to her husband. Now husband says that the salt is little more, or the chili is very more, or the dish is not that much delicious as it was used to be. Now, it is just an error in cooking. It could be rectified, but this lady, the wife, has her own belief system. Now she thinks, I'm not that much good in cooking now. My husband doesn't likes the way I cook anymore. I am getting old and I'm not cooking delicious food anymore. My worth has decreased over time. So these are own belief system. It can be good, it can be bad, it can be fake also. Even this same housewife could have a belief that my husband is not having that much understanding before. Earlier, he used to like my food. Now I'm cooking the same food. Now he's not liking it. So this can be a belief system. So belief system could be different person, different belief system. CBT aims to correct the belief system, correct the thought process, correct the cognition for the benefit of the individual. Now we'll understand how ABC model comes and how persons get affected by their own thoughts, own emotion. So A, the activating event, B, the belief. Now comes the C. Now what could be the C? C is the consequence. So, what could be the consequence? The last takeaway of it, the emotions which is carried out. So, in this case, the emotion is of disappointment. If a person is walking on the street and his friend doesn't recognize him, it could be a very normal situation. It could be that the place was so crowded that his friend doesn't saw him correctly. It could be that the friend was involved in his own busy life, or it could be the case that the uh, look of the person due to aging, it was different from way back 10, 15 or school days. So it was hard to recognize after some years. So it could be any way, but the belief of this person led him to the last emotion, that is the consequence of disappointment, self worthlessness, and hopelessness. So, this is the C, the last takeaway, the last emotion that a person carries back. So, A has happened, it could be of a few seconds. The thought is also for some time, but the emotion and its effect is carried on for a long time. So this ABC happening, the ABC, 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 another activating event, another belief, the same belief is being continued, and then same consequence. So particularly speaking, if a patient is having, let's say, major depressive disorder, then the same belief system, same emotion, same ABC comes again and again. So when this ABC repeats itself, it is the negative thoughts. So negative thoughts, negative consequence, negative emotion, and the person goes into that state of mood. So ABC, 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 and then negative thoughts, that becomes automatic negative thoughts, and the mood, the consequence, the emotion remains of sadness. So this is how a person with depressive disorder, major depressive disorders, brain or mind works. Sometimes the ABC, the automatic negative thoughts, are so much strong in automation that it doesn't require the event also, the action also, the aggregator also is not required. So we'll be discussing the ANT in coming slides. I'll share the next slide. So this ABC is understandable. Anyone wants to ask questions because the complete CBT is based on this ABC model.
No,
I kept a
anyone with any question, they may raise this question now, or we will take the questions later on. But he's saying we before proceeding, it should be better if someone has a problem with ABC.
You will be explaining this D and E.
yes, D and E. I'm explaining. I've tried to keep the presentation short so that I can consume less time. ABC is clear, then we can move to D. So A, B, and C. Now the comes DE. Now here the role play of clinician starts. So ABC is the part of the patient. Now the clinician gives the D. Now what is the D? D is the dispute. Now we have recognized the pattern when the patient speaks. We ask him what happened today, what happened last day, how did you felt, what event made you sad, what thought made you sad. Now we have recognized this ABC pattern, that the takeaway of the consequence, the emotion is this. Now the clinician's responsibility is to give the alternate belief, is to first introduce the dispute, the options which he could have thought. So, for example, if I'm a clinician, I'm psychologist, I'm treating this person, I would have told him or I would have given an option that there was a possibility that your friend was already occupied in his busy life. He had something else in his mind. The place was very crowded and it was a very normal situation. So if this is the alternate thought, then the belief would be different. Belief would be everyone is so busy now. Even I am also busy. Even this could have happened to me also. He was walking so fast. So this is the E. Now when we have a series of ABC, then we can give the alternate thought and alternate outcomes. So the effective belief is to be given to the patient. The DE part is the part of the clinician. So I'll move forward to the A and T. The cognitive behavioral therapy has its therapy goal to understand the pattern of automatic negative thoughts, ANT, and to correct it, to guide the patient develop a rational thinking. So, what could be the negative thoughts? What if I fail? I hate the world or I hate myself. I'm not good enough. So, these are fast and habitual negative thoughts, emotionally distressing, common in anxiety and depression, and it's never enjoyable. Even if someone is having a very strong, very old habit, it's not enjoyable. The person deep down within has this insight and wants to work on that if given a good knowledge about it. So, journalizing and thought sheet. Now, these are the work of clinical settings. When a patient comes, we psychoeducate the patient that they should write a journal of what was the event which made them sad, what was the situation, what was the thought which came to their mind, what was the emotion or feeling they felt, and the alternative thought and outcome. This can be given with the help of clinician, and further the patient is to be trained to self work on what could be the alternative thought. So initially the clinician, the doctor or psychologist helps the patient, creates a dispute, gives the alternative thoughts, alternative outcomes, and slowly, by working together, the aim is to make the patient independent. So, the ultimate aim is to decrease the dependency on therapy sessions, because the patient, when comes for therapy session, yes, the last outcome of the therapy session is useful. What activities, what actions, what events they have been worried for in last days, the last emotion was rectified, it was worked. But the patient comes on coming again and again therapy session. It is not the ultimate goal of CBT. The dependence is not the ultimate goal of CBT. The realization, the rationality, the development of rational thinking is ultimate. So this is the thought sheet, just a sample for understanding. The next is the CBT triangle. Now, as the triangle states, behavior, thoughts, and emotions. So, thoughts, then emotions, and then the behavior. Now, because of behavior, the thoughts can repeat themselves. Situation can change, but the thoughts will still be the same. The emotion, the last takeaway will still be the same. So this is a cycle, and as I told earlier also, after some time the patient doesn't require the aggregator also. They wake up in the morning and they are occupied with thoughts. They are repeating that behavior only. So same cycle, same result. CBT focus to change the thoughts. When we change the thoughts, we change the emotions. And when emotions change, then slowly, the behavior changes. Okay. Now, coming forward to the applications of CBT. CBT is a very commonly used therapy. It's often called PCM or paracetamol of mental health, of psychotherapy. So it can be used for major depressive disorders and specifically for mood related disorders. So even in PTSD, it can be used. In PTSD, the aggregating action or the A will be the memories, sometimes the reminder of the deceased person, the loved one who has deceased. Anxiety disorders, GAD, generalized anxiety, and even in situational anxiety it is very useful. OCD also, it is useful. Specific phobias, panic disorders, there it is useful. Sometimes in insomnia is also it's useful when the patient is occupied with thoughts, and the thoughts is the main reason having difficulty in sleep. So yes, it can be useful for insomnia also. Addiction and anger management. So who are the ideal patient of CBT? What is the patient profile which is the ideal for CBT? So in my opinion, a patient having affordability, which can afford the therapy sessions, is having good patience level, can wait for the results, can come clinic again and again, is of course the ideal patient. The patient should be motivated. A basic level of motivation should be there so we can increase that. Patient with a insight, this should be present. Goal oriented approach and cooperative patients, willing to practice homework exercise. So homework is very important, self realization is very important. These are the ideal patients. In my opinion, the patients having mild severity of depressive disorder, seasonal affective disorder, and in OCD also, these are very good profile for cognitive behavior therapy, and they usually get benefit also. In anger management also it is useful, and in PTSD also it's useful. So these are the ideal patient profiles. So someone is having severe depressive disorder and is having acute problem in sleeping also, somnia related difficulty, then CBT can be used, but as an additional, as a complementary treatment, not a standalone treatment. So next slide is CBT, standalone or complementary. Of course, the opinion differs from professional to professional. In my opinion, yes, CBT has a very wide scope of usage, and it can be a standalone treatment, especially for the mild severity cases. It can be used for relapse prevention. For relapse prevention, it's very useful because again the patient starts having those thoughts, start having those emotions, sometimes craving also in de-addiction cases. So there it is very useful. It is often combined with medication, even in severe cases. For example, there is a case of severe depressive disorder. Then we can use SSRIs and benzodiazepines. Along with that, the patient responds well, then CBT sessions could be planned after there is a good response of the treatment towards the medication. So first line of action in severe cases is of course the medicines, because we need to ensure the sleep level, hormone balance, and then we can plan counseling sessions. It can be support holistic healthcare approaches. Yes, CBD is useful and it has a lot of implementations in real life. In adolescent age group also now it is being used effectively. So there are other therapies which are derived from CBT, dialectical behavior therapy or DBT. It's a specialized therapy. It's taken from CBT, specialized CBT. It's majorly used in emotional well-being, and for borderline personality disorder, it's the gold standard psychotherapy. MBCBT is the version of mindfulness. It focuses on the mindfulness, making the patient mindful of what they are thinking, what they are feeling. ACT, acceptance and commitment therapy. Of course, it's a teamwork between therapist and the patient. And last is the compassion focused therapy. Now, this is a specialized therapy for patient having a lot of shame, a lot of self criticism. So the therapy goals becomes different. The core principle of CBT remains the same. So this is the end of the presentation. I've tried to keep CBT explanation very short. If there are any questions and answers, now we can take up that.
Thank you, Jay. It was actually enlightening because we all are homeopaths. We all do counseling daily, and so much is being talked about mental health that I wanted कि आज कुछ ऐसा session हो जो कि we all should be, the technical side of psychology. So I would request Dr. Mukesh sir to please comment.
Actually, there was a question by some audience regarding journaling, I think.
Yes, sir. She asked कि आप balance जो journal sheet है Jay, can you just give an example and fill the how to fill the the sheet?
Doc Sahib, if you can answer that,
Yes,
then
yes.
Yes. So for journaling and for thought sheet, now journaling is the notes which patient write them
yeah.
by themselves. For example, sometimes I give this type of diary to patient. If they are more writing habit, sometimes I give them this. So journalizing is self activity. Now, when they are more in writing, because for therapy sessions we require some basic rough work
Yeah.
to understand what they have been thinking. So journalizing is self writing, and the thought sheet. Now, the format of thought sheet, every clinic has their own protocol, but the main elements of the thought sheet is, of course, the A, B, C. And when we educate them about the alternative effect, alternative outcome, then we tell them to write that. Now, if a patient is working on that after few days or maybe after 5, 6 sessions, they're writing A, B, C, and then now they are thinking again that I felt very sad about it.
Mm.
Someone criticized me, someone didn't like my work,
Mm.
but I'm feeling sad about it. Is there an alternative option? Because
Mm.
I'm feeling sad, I'm suffering also. So
Mm.
I can be neutral towards it. I can say that yes, it is their opinion. I respect them. So alternative emotion could be I respect their opinion.
Okay.
Now, when they start having these thoughts that I should respect the participant, I should respect what opinion is being given to me, or I can actually change, I can improve on that.
Mm.
Now their behavior is also changing with that. So this
Okay.
is how CBT works, the APC model works. The DE part, initially, it's responsibility of the physician to
Mm.
introduce the DE to the patient, but ultimately the patient is to be trained to have the best outcome.
Okay. Okay. Doctor, one more thing. I have seen uh, people having very specialized journaling diaries where they track a lot of habits and good things and bad things. Is it recommended to have that detailed journaling?
No, as professional environment, we need the very short version of all these ABCDE.
Okay.
So if the action is been written by the patient, let's say in 2 paragraphs,
Yeah.
practically in clinic, if we are just going through the events, the actions, then it will take a lot of time. So after 1 or 2 sessions, I will educate the patient that
Hmm.
try to be more short, and I will educate them to use the specific words. Like I
Okay.
have explained the terms here.
Hmm.
Sometimes I give them the list, what are emotions, what emotions they are feeling, because a lot of emotions they haven't felt. The joy,
Okay.
the
Okay.
compassion,
Hmm.
these emotions they haven't felt from a long time.
Hmm.
So we try to spark that emotion again. We try to reintroduce them. So real life scenario, as clinician, we should try to get a very short version of ABC.
Okay. Thank you. One more question. While you were talking about mindfulness, can you slightly elaborate that?
So mindfulness is an approach, is being in the present moment.
Hmm.
So originally it's taken from Ayurveda. I mean, mindfulness is a new term in modern psychology. So living in that moment, not being preoccupied with their own beliefs, just living, being present, what is happening, not feeling else. So this is mindfulness. It's another topic. So I'll
That
just
is why
give
I
it.
wanted to. It is done by medical professional, or because I think I have read these things in Buddhism and various
Yes.
spiritual practices. So is it to be done by them, or the professional medical professional can do it?
Mindfulness is an approach. In meditation also, it is said that the aim is to become mindful. So yes, there's a specialized now. We have used specialized terms for it. It
Okay.
can be practiced by any healthcare professional.
Okay. And sir, what will be the advice for, in cases of bipolar patients?
In real life scenarios, that bipolar patients we cannot treat without medication because we need the mood stabilizers,
Yeah.
especially the lead carbonate.
Yeah.
So their medication also has to be changed with seasons. So you must
Okay.
be knowing better than
Yeah. Yeah.
me.
Yeah. Yeah.
So in real sense, we can do family counseling. We can decrease the episodes. We can
Okay.
make them aware of yes, I'm going into episode or I'm having a panic attack और
Yeah.
हिंदी में कहते हैं कि ये तेजी के दिन शुरू हो गए हैं जैसे गर्मियों के
जी जी
है ना.
जी जी.
So we can make them aware of that.
Yeah.
But
Okay.
solely CBT is not very
No.
useful in bipolar patients.
Okay, okay. Thanks a lot. Your lecture was indeed very interesting and very useful for homeopaths. We homeopaths really appreciate your the insight you have given. But can we have some more basic uh, knowledge about, because we use a lot of mental symptoms for prescribing. If we can have a session with you in which we try to understand the basic things, Mrinalini can
Yes, sir.
cooperate with you, है ना? नहीं,
Yes, sir.
because it will be very useful,
Yes, sir. Yes.
क्योंकि हमें तो टर्म्स जो वो हैं नॉर्म
Hmm.
बेसिक वाली वो भी नहीं समझ आती. तो जैसे इन्होंने बोला कि वो पेशेंट के दोस्त ने देखा और उसने रिकॉग्नाइज नहीं किया तो उसको लगा वर्थ, तो बिल्कुल ऑरमेट जैसी पिक्चर आ रही थी. तो
Right, sir. Hmm.
बेसिकली अगर हम और सीखें तो हमारे लिए और यूजफुल हो सकता
बिल्कुल,
है
sir.
ना.
So he's
थैंक यू
very
डॉक्टर साहब.
he's very young, sir. He's just, I think he's just 30 years, and he's got so much of
या दैट्स वेरी गुड ना.
his insight,
बिक
and he's been full time working as the head of his clinic. So
राइट.
when I just met him during the course of postgraduate diploma in mental health. So
ओके.
so he's been a wonderful,
हाँ.
जो भी कुछ भी समझाने के लिए has been wonderful. So I
नहीं
thought
नहीं,
we all should
it has been a very
benefit.
useful session. Really, we learnt a lot, but there is lot to be learned from him, because we need such knowledge कि जो हमारे mental symptoms हम अपनी तरफ से करते हैं लेकिन हमें पता नहीं कि वो क्या, उनमें से क्या कॉमन है, क्या अनकॉमन है, कौन सा peculiar है. अगर वो सब चीज़ें हमें समझ आने लगें तो बहुत यूजफुल हो सकता है.
Right.
एक वर्कशॉप कर लो ना, ये तो बोला.
Hmm. Yes.
Thank you,
अब
ma'am. Thank you,
हाँ,
all the
थैंक्स अ लॉट
seniors.
डॉक्टर.